acoustic conditions in living rooms of care facilities for the elderly. It was part of a bigger research in which we also looked at other physical aspects like lighting and air quality. But I was dealing with the acoustical part of it. Short overview of the presentation, introduction with some background information. I will explain you about the methodology we used. We did a field research in a care facility, and we did the research in 5 living rooms, and we measured in all these 5 rooms. After those objective measurements, we picked out one most worst room of the 5, and we measured. We did an intervention, and we did also measurements afterwards. So I'll show you the results and analysis of these measurements, and at last, but not least, the summary. As you probably already noticed, the world's population is aging rapidly. For example, in the Netherlands, about 160,000 older adults live in nursing homes or care facilities, and most of these people suffer from hearing loss due to biological aging. So that often leads to communication problems, and by having communication problems, sometimes you can also encounter social isolation, loneliness, or even depression. Besides hearing loss, also the acoustic quality of a room can have influence on the daily limiting of these people. For example, if a room is very reverberant or too noisy, it also makes it almost sometimes impossible to have good conversations together. Hearing loss due to aging is also called presbyacusis, and it gets most severe in the frequencies above 2000 Hz. This graph shows the average audiograms for adults, for males as well as females. The females are the dotted lines. And what the graph also shows is an increasing steepness with increasing age. The relationship between presbyacusis and speech intelligibility, the human speech envelope is somewhere in between 125 Hz and 8000 Hz. And especially where we noticed the highest hearing loss, in these frequencies contain a lot of information to understand speech. So you can understand it's a problem for all the people. To show you, I would like to show you a little movie we made last year together with Ecofon to give you an impression of what a difference in reverberation in a room can do to what a person with hearing loss hears. And first we will hear the difference in what a person hears without hearing loss and a person with of 80 years old with hearing loss in a sound absorbing room. And in the second part you will hear what both hear in a very reverberant room.
This is a speech intelligibility test voice that is meant to be used for setting the acoustical output level of a sound system. This is a speech intelligibility test voice that is meant to be used for setting the acoustical output level of a sound system.
Now you will hear the difference between what a 20-year-old person hears without hearing loss and an 80-year-old person hears with hearing loss in a very reverberant room.
This is a speech intelligibility test voice that is meant to be used for setting the acoustical output level of a sound system. This is a speech intelligibility test voice that is meant to be used for setting the acoustical output level of a sound system.
Okay, yeah, this is a little bit big contrast, I have to admit, because it was we made these shots in the reverberation room in our acoustic laboratory. So in the reverberant room, the reverberation time really exceeds, between higher frequencies like 4 seconds to low frequencies up till 10 seconds. So in practice, we won't encounter these rooms, I hope. In general, all acoustic criteria there are for rooms are set for listeners with normal hearing skills. And if we look to care facilities for the elderly, we often encounter rooms with material finishes that are acoustically reflective. Most of the times, the reason we hear is because it's easy to clean. Actually, there are really a few studies done in care facilities, long-term care facilities. And so the aim of the current study I present is to provide more insight into the type of sound sources and sound levels occurring in these rooms. And on the other hand, the room acoustic quality of these living rooms and the extent to which a room acoustic intervention improves the speech intelligibility related to age and hearing loss. As said before, we did a field study in 5 living rooms. We carried out objective measurements, long-term sound level measurements, as well as some room acoustic measurements for room acoustic parameters. In one of the common rooms, we applied an intervention, and we again carried out the objective measurements afterwards. This is a plan with the 5 plans of the living rooms we measured. For the long-term sound level measurements, we made audio recordings, and to be able to make these recordings, we had to ask for informed consent. So the family of the residents signed the informed consent, because the residents they were living in these living rooms were having dementia. So that makes it quite difficult as subjects to study. The acoustic parameters we looked at were the A-weighted equivalent sound level and the A-weighted peak sound level. And also we made manually annotations of these audio recordings to see what kind of sound sources there occurred and the level of them. This is the measurement setup. As mentioned before, there were some limitations because of dealing with people with dementia. So we had to make sure that they couldn't touch any equipment, because otherwise they would influence the measurements. So we tried to apply them in corners. Sometimes it was necessary, or here in the middle of the room where they couldn't touch it, couldn't reach it. This is an example of one of those long-term measurements over 3 full days. And this graph shows the A-weighted peak sound level. And we annotated only the levels higher than 100 dB. And here you can also see the night periods, and as well as the day periods. And of course, the living rooms are only used in day periods, so we only looked at these periods. we used 13 labels to do the annotation, and we counted every peak level. The labels I will show you later in the results. Then the room acoustic parameters. We did measurements for the reverberation time, the background noise level, and the speech transmission index. This overview shows the 5 living rooms again, and with all the receiving positions we used for the measurements, and all receiving positions were also used as source position, and between every combination of source and receiving positions we measured the impulse responses. Then we come to the results of the 5 living rooms. Here you see a graph of the A-weighted equivalent sound levels we measured. And every color represents a living room. So for example, here we have 2 orange lines. So we measured in this specific living room for 2 full days. And you can see in this living room, 50% of the time, the level of 54 dBA was exceeded. And for example, in this living room, on that specific day, the level of 64 dBA was exceeded 50% of the time. If we look at the A-weighted peak levels, yeah, it's a little bit not visible anymore, I see, because this part is marked to show that we only looked at the levels higher than 100 dBA to annotate. And this is in one of the living rooms measured. Here you can see all the different kind of sound sources we could hear by listening back the audio recordings. And you can see, for example, cleaning and doing the dishes provides a lot of peak levels above 100 dBA. And in this specific living room, at one day, probably somebody was celebrating his birthday because there was a lot of hand claps, so they sang happy birthday and clapping again. The acoustic parameters, the results, I will show you first of all the reverberation time. There's quite some differences in between the 5 living rooms, and the one in orange we choose to apply the intervention, because also the ST measurement results showed that the ST value was dominated by the reverberation time. In that same room we had a quite low background noise level compared to the other 4 ones, and I was also thinking about doing an intervention in these living rooms to lower actually the background noise level, but that was too complicated regarding because it was mainly caused by the ventilation system, and it was too difficult and too expensive actually to make modifications and an intervention in that. In short, the results of speech intelligibility, I show them in 2 different graphs actually. Left you can see the average T values between all combinations of source and receiving points within one zone. So a zone is, for example, a table with chairs and people chatting around the table. And at the right you see the ST values between zones. So for example, between someone that is sitting near the television and other people sitting at the dining table. So this is a picture of the living room where we applied the intervention. At the left side, you see the living room before the intervention, and at the right side, you can see that we applied sound-absorbing panels, 35 square meters in total. And first, to determine the amount of sound-absorbing panels, we made a CAD model, a 3D ray tracing model, and we aimed to lower the reverberation time with 50%. Okay, the results of the measurements after the intervention. First of all, the A-weighted equivalent sound levels. For example, here at the 50%, so at the median, it was before the intervention 56 dBA, and after the intervention it lowered with 1 dB. So, but if we look at the peak sound levels, there is a bigger difference. Before the intervention, we saw that 50% of the time the level of 88 dBA was exceeded, and after the intervention only a level of 47 was exceeded. As I said before, we aim to lower the reverberation time with almost 50%. And the measurement results showed that it was almost 50% reduction. So the CAD models sometimes work out pretty well. And also I pointed out here the difference in ST value. So before the intervention, the ST value, this is the mean value again, between all source and receiving positions. It's 0.63, and afterwards it was 0.74, so quite a big difference. But I was wondering, because all these T values are for normal hearing persons, and of course in these care facilities older people are living, and most of them are above 80 years old. So I was wondering actually what the effect would be for these people with hearing loss. But as I said before, they were having dementia, so it was really difficult to have any feedback of the people themselves. So I tried to make it visible by calculating the ST. Here you see an overview of the whole ST calculation. Most important, I will keep it short, most important is that actually we have a part in which the reverberation time or the impulse responses are integrated, and a part in which the noise, the background noise level is integrated. For the impulse responses, we used the measured impulse responses in the room. And in this part of the calculation, it's possible to integrate the auditory threshold. So I integrated the threshold levels for people for male people in steps of 10 years old. And if we look at the results, then we see a quite big difference in between the effect of the ST value before and after the intervention. So at the left side, you see the delta ST of the measurements. Here you see the delta ST of the calculations for the different audiograms for people between 20 and 30 and so on. And so then we see a very steep decrease in the delta ST. So, and for the people of 80 years and older, we only have an increase in the ST value of about 0.05. And if we know that the just notable difference of the ST value is 0.03, then maybe we should wonder if such interventions are really helping these people to have a better understanding of speech in these living rooms. So that was something I wanted to ask you, actually, if you also think there are maybe also other ways to improve the speech intelligibility than only applying sound-absorbing material. What's most of the times the first what comes up in mind if we are talking about improvement of acoustical climate in rooms. This is a short summary, but you're really standing there, so it's the last sheet. So a summary of the results before and after the intervention. We found a significant reduction in the A-weighted equivalent sound levels and peak sound levels. Also a significant increase in STI values, especially for people without presbyocusis. But with presbyocusis, then the STI value decreases very fast after the age of 50 years old already. So, but what we also did was trying to get feedback from the caregivers, and they were very positive about the intervention. And they told me they experienced the new situation as more quiet and more. They were less tired at the end of the day, because also the people, according to them, reacted better in this acoustic situation. They were more calmly, less making noises, etc. So in that way, it seemed to have a positive effect. And later on, we changed the whole room. This is the living room. So also the kitchen was placed in another situation, but still they were having the acoustics panels. So they were glad to have this intervention.
Thank you very much, Nicole.
Yeah.